Welcome to Evidence Mastery with Dr. Massoud Toussi. Please note that this video is for education only and will not replace your doctor's advice. While the principles of oncology overlap, today's evidence review is specifically focused on the blood and bone marrow. We are examining acute myeloid leukemia, or AML. To understand the scale of this disease, we look at the epidemiological data. In the United States, there were approximately 22,010 new cases of AML documented in 2025, alongside roughly 11,090 deaths. It comprises about 15% of all childhood leukemias, often developing in the first year of life. However, incidence sharply increases with age. AML is the most common acute leukemia in adults, presenting with a median age of onset at 68 years. A significant portion of these adult cases occur as secondary AML. This means the leukemia develops as a direct consequence of prior chemotherapy or radiation therapy used to treat a completely different, unrelated cancer earlier in the patient's life. AML is not a monolithic condition affecting the young. It is a highly complex malignancy that predominantly strikes older adults, and its onset is heavily influenced by aging biology and the patient's prior medical history. The origin of this disease begins deep inside the bone marrow microenvironment. In a healthy system, a pluripotent stem cell acts as the common ancestor, differentiating into all the functional blood elements the body requires. AML is triggered by a series of acquired genetic aberrations that strike exactly at this stem cell level. These genetic errors lead to a failure of apoptosis. Apoptosis is the programmed cell death that normally clears out damaged cells. Without this regulatory mechanism, the damaged stem cell survives and divides uncontrollably. This uncontrolled clonal expansion is paired with aberrant differentiation. Instead of maturing into functional red blood cells, white blood cells, or platelets, the marrow produces a massive quantity of immature, defective cells, known as blasts. Because these malignant blasts are long-lived and constantly replicating, they physically crowd out the healthy marrow. The physical space required for normal blood production is entirely replaced by a dense mass of non-functional leukemic cells. This single microscopic genetic error scales up to orchestrate a catastrophic systemic failure of blood production. The symptoms patients physically experience are the direct downstream result of this marrow replacement. Modern hematology no longer approaches AML as a single disease. It is a highly heterogeneous group of malignancies, and clinical outcomes are dictated almost entirely by the specific genes involved. The International Consensus Classification, or ICC, is the standard diagnostic framework used to categorize AML subtypes. Instead of looking solely at cell shape, the ICC categorizes the leukemia based on precise gene or chromosomal changes found within the malignant cells. One vital branch is acute promyelocytic leukemia, or APL. Defined by the T1517 translocation, APL strikes a younger demographic with a median age of 31. It requires immediate identification because patients frequently present with severe, potentially fatal coagulation disorders. Another distinct branch is therapy-related myeloid neoplasm. This classification is directly tied to those prior cancer treatments we discussed. Specific drugs dictate the latency period. For example, prior treatment with alkylating agents typically results in AML 5 to 7 years later. Determining the exact genetic classification dictates the clinical pathway. Identifying the specific chromosomal aberration is the prerequisite for selecting an effective targeted treatment plan. Because the bone marrow has been overrun by malignant blasts, normal hematopoiesis is severely disrupted. This leads to rapid onset clinical consequences just days before diagnosis. The first is anemia, caused by the severe drop in red blood cells. Patients present with profound fatigue, weakness, visible pallor, and dyspnea, or shortness of breath upon exertion. The second is thrombocytopenia, the critical loss of platelets. Without platelets to clot the blood, patients experience mucosal bleeding, easy bruising, and petechiae, which are small red or purple spots on the skin caused by minor hemorrhages. The third is granulocytopenia, a severe deficit of mature white blood cells. This leaves the patient highly vulnerable. A fever may be the only initial sign of a rapidly progressing, life-threatening bacterial or fungal infection. While less common, occurring in only about 5% of patients, leukemic blasts can infiltrate extramedullary systems outside the bone marrow. When these cells invade the skin, they cause visible papules and nodules known as leukemia cutis. The triad of anemia, bleeding, and sudden severe infection serves as a direct mechanical indicator. The body's normal blood production factory has shut down, completely hijacked by malignant cells. The diagnostic process begins with a complete blood count and a peripheral blood smear. Finding pancytopenia, a reduction in all types of blood cells, alongside circulating blasts heavily suggests acute leukemia. To confirm, a bone marrow aspiration and biopsy are routinely performed. In a positive AML diagnosis, blast cells will typically constitute between 25 and 95% of the total marrow cellularity. Clinicians then use flow cytometry, a laser-based technique used to detect chemical and physical markers on cells, alongside various histochemical studies. Finding Auer rods, which are linear crystallizations in the cytoplasm, is pathognomonic, meaning it definitively confirms the myeloid origin of the blasts. Once confirmed, the sample is run through a rigorous 5-step genetic diagnostic algorithm. The first step filters for those AML-defining recurrent genetic abnormalities, like the translocations we discussed earlier. If absent, the algorithm moves to step 2, checking for a TP53 mutation variant allele frequency. Identifying a TP53 mutation immediately places the patient into a high-risk category, altering the treatment approach. The sequence checks for myelodysplasia-related genes and cytogenetic abnormalities. If the sample filters all the way to step 5 without triggering a match, it is classified as AML not otherwise specified. Processing the marrow through this strict algorithm ensures every genetic vulnerability and risk factor is mapped. It provides the exact blueprint required to build the therapeutic strategy. Because of the disease's intensity, treatment protocols are bifurcated. The clinical pathway is dictated primarily by whether a patient is evaluated as medically fit or medically frail. For medically fit patients, the initial protocol is induction chemotherapy. The immediate goal is to induce complete remission, which is strictly defined as having less than 5% blast cells remaining in the bone marrow and the restoration of normal blood counts. The standard induction regimen is known as 7+3. It consists of a continuous intravenous infusion of cytarabine for 7 days, paired with 3 days of an anthracycline drug. This triggers severe myelosuppression, requiring meticulous supportive care involving transfusions and broad-spectrum antimicrobials until the marrow recovers. Precision medicine is now integrated into this regimen. For patients with an FLT3 mutation, a specific genetic driver of rapid cell growth, adding the kinase inhibitor metastarin to the 7+3 chemotherapy has been shown to prolong survival. Following remission, patients enter the consolidation phase. To prevent relapse, standard practice relies on high-dose chemotherapy or an allogeneic hematopoietic stem cell transplantation, effectively replacing the patient's entire immune system with healthy donor cells. The major exception for fit patients is the acute promyelitic leukemia subtype. APL is treated with targeted therapy using tretinoin and arsenic trioxide. This avoids conventional cytotoxic chemotherapy entirely while achieving a cure rate greater than 90%. For the medically fit, the objective is the calculated eradication of the leukemic marrow, followed by targeted genetic cleanup and the transplantation of a healthy hemopoietic system. We now shift to the medically frail pathway. With the median age of AML diagnosis at 68, a large portion of patients possess comorbidities that make surviving the intense toxicity of the 7+3 regimen impossible. For these patients, clinical practice uses lower-intensity targeted therapies. Frontline treatment often relies on DNA methyltransferase inhibitors, such as decitabine and azacitidine, which modulate DNA by reducing the methylation of tumor suppressor genes. This chart shows the survival curve comparing older patients receiving azacitidine alone versus those receiving a combination therapy. Combining azacitidine with venetoclax, an inhibitor that directly blocks the BCL2 proteins keeping cancer cells alive, yields a distinctly higher incidence of remission and significantly longer overall survival. If the leukemia relapses or proves resistant, second remissions are difficult but possible. Options include salvage chemotherapy or newer, highly targeted agents like revumenib, a menin inhibitor utilized for specific translocations. By utilizing targeted genetic inhibitors instead of systemic cytotoxicity, modern hematology offers viable, life-extending remissions to older patients who previously had no treatment options. When determining overall prognosis, the leukemia cell karyotype remains the strongest predictor of clinical outcome. We stratify patients into favorable, intermediate, or poor risk groups. Clinicians also monitor minimal residual disease, or MRD. Using advanced flow cytometry, or PCR tests, they can detect leukemic cells down to 0.01% of the marrow. Having a detectable MRD prior to a stem cell transplant is an independent prognostic factor for an adverse outcome. I hope you enjoyed this video. Please feel free to share your experience or questions in the comments. Please note that I won't answer personal questions. If you found this video helpful, don't forget to subscribe to my channel. For a deeper dive into the data, look for the upcoming 2027 publication of Real-World Evidence, Diseases and Drugs, a comprehensive reference for healthcare professionals.